just curious from your perspectives, in many of these examples today seem to be larger systems, broader systems. And is there an optimal point where this really starts to create an impact? And the reason why I phrase the question that way, if I was to look at, let's say, ABC fire EMS service that is running fire suppression and EMS and managing those calls, a lot of this work doesn't necessarily seem to translate into, if there's not stacking of calls, if there's not delays in response times, then maybe not as applicable, is my question to you, as compared to, do you have to go hunting for solutions to problems that may not exist? And really, how do you identify if you're the problem system?
I can take a first crack at that. I think it is applicable to all systems. I think that reducing, so those smaller agencies, if they're going to everything 100% lights and siren, then it would reduce the safety issues for them if they, cut down that lights and siren responses to appropriate things where they aren't needed clinically that way. Yes. Do they have an issue with efficiency? If they're running very low call volume and they're always available and they're getting to 95% of their calls without bringing in second due and that sort of thing, you're not going to get the efficiency of stacking calls. But I think that that's equivalent to that emergency department thing, the waiting room in the emergency department. When it's a lower volume emergency department, people walk in the door and there's a bed available because they have 5 beds and it's a really low volume rural emergency department. You're going to go right into a bed and be seen pretty quickly. But if it's a big high volume place, more likely you're going to be in the waiting room. But everybody can benefit from the safety aspects of not having a crash like they just had in Utah and taking out one of your ambulances, 3 of your EMTs, and 1 of your EMT apprentices or observers. So.
And I would say 2 answers, Greg. One is there might be an economic crisis that comes along to drive some of this. There might be a utilization problem in a system that comes along to drive some of it. There might be a labor problem that drives some of it. But there's the opportunity to do it because it's the right thing to do, and doing it before any of those things land in your area or your agency or your county or whatever. Because if that's the case and we're making the change in a hurry, it probably won't be implemented as well if we did it ahead of the actual need. I do think, and your question, I thought this is where you were going, I do think it's a little bit different for us in Michigan than some of the other states that we've heard from, because we have a county medical director or a medical control authority director. So if one agency were to stand up in Macomb County and say, look, we're not going priority 1 to anything other than this, this, and this, that decision might be left to the vote of the rest of the agencies who might prefer to have their head in the sand and keep doing things the way we've always done it. So it is hard to make the changes on an agency by agency level. And we also know that in parts of our area, there are agencies, whether they're public or private, who are using the exact opposite message to grow staffing, buy vehicles, add personnel, whatever, using the scare tactics that have just been debunked to grow their agencies. One guy over here says we need to go buy 7 ambulances and hire 25 paramedics so we can be on scene in 2 minutes. And the very next agency in the same town says we should send BLS units to these calls, we should stop running hot, and maybe we should put a nurse navigator in the dispatch center and stop going to some of them altogether. In the structure that we have in Michigan, implementing some of these changes at an agency level becomes very difficult because the medical direction is countywide. I've thought at Medstar, we're owned by 2 health systems. Somebody wants to roll out whole blood, we've got a perfect access to do it. But then I think, wait a minute, I have to go and ask all of the other agencies in my community if we want to pass a protocol to do this. And you know how that's going to go. So some of these changes are hard to implement in systems like ours. Nonetheless, the effort should be put in whether there's an economic or a clinical or a utilization crisis, or because it's the right thing to do. And I'd like to have a county-wide or a region-wide discussion about these kind of this knowledge And I'd like to hear the opponents come out and try to present the reasons to continue with the 1978 model, because that case gets harder and harder to make. But if we don't put forth the effort to start the discussion, we're going to be having this discussion at the 4th Annual Safety Summit too, because we got to move the needle.
And Chief, you raise a really good point. Even in rural communities, and maybe more so in rural communities, they're having the staffing issue with where they really do need some ALS coverage because they've got long transport times, long responses. Just finished a project in a rural community in Illinois where they had a hybrid of systems, some fire-based, some commercial, some volunteer, and everybody, even the fire-based services, were having trouble getting paramedics, et cetera. And our recommendation was that everybody should staff their units at the BLS level. The paramedic covering the county work in the hospital, because really there's 2 ALS calls a day, 24 hours in that entire county. Have that paramedic working in the ER, employed by the hospital, doing clinical care literally the entire time they're on duty, get called out for the cardiac arrest, for the chest pain, for the whatever, and even at a 15, 20-minute ALS echo response, they're getting a local BLS ambulance, oxygen, aspirin, nitro, all that sort of stuff, 12 lead acquisition and transmission, even before the paramedic gets there, in case additional care is needed, which in most cases it probably won't, because the next drug after those is really diesel. Just fundamentally looking at the clinical care that we're providing, and are we delivering good, well-qualified personnel who are well utilized to do good ALS assessment, interventions, et cetera, is regardless of your system size.
So for those that have come up with the tiered system, have you guys seen a decrease in the number of transports? So for those that have like the chase car, the paramedic fly chase car, do you see a decrease in the number of transports overall, or is it more of just a decrease in the ALS transports?
There are like 5 questions in there, so good job
All right.
for doing all that. Whether or not someone needs to go to the hospital clinically is something that each system needs to address, how they want the protocols, et cetera. What we're seeing across the country, and there's a study that's going to be published in the Academy's Emergency Dispatch and Response here shortly, response volumes per capita are going up. So once you normalize it for population, so you truly look at 911 requests for EMS are going up at its core, per capita, but the fastest growing determinants are the low acuity calls. So we need to figure out what is the right process to get the right patient, the right response with the right disposition. And working together with the community medical control authorities, payers, everybody, figuring out how do we reduce, how do we prevent avoidable emergency room visits while at the same time not getting a financial hit, because we're trying to do the right thing by the patient by referring them to wherever they more appropriately need to go, is a community discussion. And what we're seeing, and in communities that have had that discussion, like when I was at Medstar, like what they're doing in other communities, where they're getting reimbursed for not taking patients to the hospital. When we did that several years ago, even after ET3, our average transport ratio went from 81% to 67%. Because as everybody in this room knows, if they've spent more than 20 minutes on an ambulance, the majority of patients that we respond to don't need to go to the ER.
And I'd say those calls are going up partly in relation to the aging population. You know, one of my big interests right now for the last few years has been falls in the elderly and how we're taking care of that. And it truly is an epidemic. For most, I would bet for almost all of your agencies, if you look at the #1 call that you go on by call type, it's falls. And many of those are elderly. And it runs the gamut from the lift assist all the way up to the, you know, traumatic head bleed. But I think that the growing or aging population is one of the reasons for that increase. I think there are also some others. And we still have to be unique. Nobody today, I don't think, has talked about, maybe Michigan doesn't do it, has talked about the advanced EMT. We have transitioned a lot in my agency. We have increasingly transitioned our ALS units into advanced, we call them intermediate ALS units, but it's just Pennsylvania language, but using advanced EMTs. And, you know, there are other ways that we really haven't brought up today to do that. I mean, it could be, you know, having a lot more BLS units, which I think most places need to do. It could be transitioning some of your ALS into advanced EMT units. It could be doing things if you're addressing an increasing fall population with lift assists. You know, in Niagara Falls, Canada, they have a lift assist response team. Talk about alternative response vehicles. They have a lift assist team that is an EMT and a physical therapist. That when they do the lift assist, that physical therapist can do some additional assessment of the individual for maybe the potential to benefit by physical therapy, some additional, you know, look at the living quarters and that kind of thing that can help prevent the falls, et cetera. So I think there's a lot of stuff that we have to just change the way we've been doing it.
I'd say in our system, as far as transports are concerned to the hospital, we've had a marked decrease in transports. Absolute numbers are hard to tell, but the percentage compared to the rise in 911 calls really show a decrease. Of course, I presented about our CMED teams, but earlier on in the presentation, I showed you like that huge rainbow of 9 different alternative response types that we have. And each one of those prevents transports, and they're all specifically designed that no transport vehicle is brought to that scene initially. And so so they're not even set up to transport. Now, there's a few exceptions to that, okay, but in general, it's a whole nother step in order to get the transport. You have to actually make the decision. You have to call in the ambulance. There's a lot of barriers, not barriers, but it makes it so that it's not just a default to transfer somebody to the emergency department, if that makes sense.
How did you get your citizens to accept that? I feel like in our system, the expectation, as it has been forever, is to transport the patient. Was it just a slow process over time with all those ancillary services? Or did you just get to the point where you were just like, look, we're not transporting you. We are giving you the service that you need. The ER is not it.
Yeah, ours has been really a community project to educate people about that. And I'd say that the best education that we actually give is each individual call on scene, okay? Because that's where the questions come. How come you don't have an ambulance? How come you're saying I don't need to go to the emergency department? How come you are arriving 45 minutes after I called 911? And so we really educate our providers to be able to educate and speak to the public. We also try to do it on a wider scale with news and things like that. But I'd say where it really hits home is when we can educate each individual person and let them know things like, if I take you in this ambulance to the hospital for this problem, that you don't need to go to the hospital, but even if you wanted to go to the hospital, you don't need to go in an ambulance. Then if we take you, then you're preventing this ambulance for arriving on your mother when she's having a stroke. Okay, and when you talk to people like that and let them know that it's greater than their, myopic situation, most people are reasonable about that, and it kind of is an aha moment.
Yeah, I would reinforce that. I mean, I think what we are living in right now is a product of systems that we created. The EMS community is responsible for where we are right now in terms of the services that we've provided. And I'm not convinced that the community expectations are that as much as they are our expectations for the community, on behalf of the community, You know, the thing right there, the culture is changing. We all need to accept that and be open to, there are a whole crapload of models where we can do things better. I mean, in some cities, the Colorado Springs model will work very well. In other cities, it ain't gonna happen because of operational and political issues. But to go back to Matt's comment earlier, in terms of the customer evaluation surveys or whatever, you know, what did we call them in the emergency department way back when? Bronsky scores. I mean, well, yeah. And when those started, they were designed to give the answers that we wanted, as opposed to being designed now to get the answers that we need. So we need to get out of our rut.
And I'd like to follow up on something that Dr. Krohmer said, and specific to the question. I think the public believes us explicitly. If we collectively went to our communities and said, look, we all used to believe this. This is what we came into this business believing. We were trained to believe this. And now in X years, we've realized that some of this stuff just isn't that anymore. And here's what we've collectively came to believe. And here's the changes that we're going to make in our community. I think well presented, the public says, well, these are the experts. Odd to hear it from them too, but let's let them do their thing. But you can't say that on Tuesday and then stand up in front of council on Wednesday and say we need 15 more people because we got to cut the response times down. We can only be on one side of that discussion or another, and if we can't own that everything's not an emergency collectively, then it's very hard to make broad changes because there'll always be somebody from within. We don't need to worry about the public shooting at us. Bill, somebody said last night in our discussion, we get into our silos. And I interrupted the conversation and said, they're not silos, they're gun turrets. We shoot at each other from these things. And we've got to do it collectively or it'll be a fragmented change at best.
Yeah, this is something that I couldn't, and I'll turn to the Fed in just a second. This is something I couldn't say as a Fed. EMS is its own worst enemy. We can't agree on anything. And things that are happening are because of the special interests in EMS, where the EMS physicians can't say, we're not going to support this legislation because it doesn't include reimbursement for physicians' activities. Where any EMT can say, and this doesn't happen, but it's an example of it, we don't support blood programs in the field because reimbursement for EMS across the board is so bad, you can't fight for reimbursement improvements only for blood transfusions. We as a community need to get our act together. Jody, as the Fed.
Oh my God. Thank you, former Fed. So I guess going back to the tiered approach, I think that talking about the benefits of that for all disciplines for the public is really, really important. In the dispatch center, and anybody who transports knows, we get the transports called in from the hospital, not the scheduled ones, but just the regular transports because maybe this person, is a stroke patient and this hospital doesn't specialize in that, right? It may not be an emergency that they're asking for when they call the first time or when they call back the second time to check and see where their rig is at. But at some point, they're going to call back and they're going to make a non-emergency call, an emergency response because they want to get somebody there. They're looking for something timely. And when you adopt a tiered approach, you're really utilizing your resources much more appropriately. You don't have to necessarily expand the number of staff. You just have to utilize them better. So when you're doing the public education, start right from the 911. Have your public understand what to expect when they call 911. What do protocols sound like? Why are we using them? Because the emotional reaction of your patients when you get on scene are absolutely impacted by the 911 call. So if they know what to expect right from the beginning, then when you get on scene, we can educate on why it's better for them that they're maybe not transported if they don't need it, and it's utilizing resources more appropriately to free up that ambulance for a real emergency, then we have those resources available, because people will just keep calling back to 911 if those calls are stacking up, and then you're really wasting resources. You're putting public and your responders at risk. Now they're running lights and sirens for something that they absolutely didn't need to begin with.
In regards to the tiered response, I think one of the important partners to have in that conversation would be the labor organizations. And I don't know if anyone's representing the MPFFU or the IFF today, but I'm just curious if you have any insights on how we could sell an idea like this that could potentially impact the labor organizations, how we could involve them in this culture change.
So part of what we did in Fort Worth started with a request by the labor union from the fire service for an additional 240 people, because their average time on a task got to be over 0.2, meaning more than 20% of the time they were on duty, they were on a task. And they said to the city manager, we need 240 more people. And the city manager said, no, you don't. We can't afford that. You need to go on fewer calls. So he used their resource request to start driving that response prioritization, which the system, including the fire chief and the fire union being in all the meetings, et cetera, reduced the fire department's call volume by 40%. And that was all well and good until the fire union realized their call volume had decreased 40%. And then they started, oh no, we got to go on more calls, got to go on more calls. You just got to find that balance. And call them out on some of those questions. Say, if you need 240 people to get to a UHU of 0.2 or less, there are other ways to do that. And I'll share this with you. And I had an aha moment after having some discussions with some innovative fire chiefs. The fire service has done an amazing job at response prioritization and tiered deployment for years. In most communities, if you call 911 because there's a fire alarm in a commercial building at 12 noon and nobody smells smoke, what is the typical response from the fire department to that call? One engine, typically no lights and siren. 10 in the evening, flames coming from a residential structure, and there are people at home. Who goes on that call? Everybody. Fire service has been doing this for years. All we're saying is apply that same principle of risk versus resource to medical calls. It's no different. You've got the same type of information. Change your response pattern based on the information that you have when the call comes in.
So I was just going to make the comment that if you look at every agency, call volumes, responses, requests are going up. It's the aging population, but it's also chronic disease. Chronic disease is actually what we're going to face for the next 25 years. We're going to have to figure out how to deal with chronic disease, and simply taking to the hospital is not the solution. I can tell you that I sit in an ER, and our ERs just keep piling up, and that's not the solution. We have to think about how, and you look at other countries, you look at Canada where the wall times are 4 hours for some ambulances. You look at, I was in Taiwan where the entire hospital, 125 or 50 patients in the lobby of the main entrance waiting to be admitted to the hospital. That's how full they are at their national hospital. We're headed that way if we're not smart about how we do things, and we need to rethink this model. I think the concept of the dead horse is absolutely correct. We're on a horse that we're not going to be able to get out of the solution by having more rigs and more response people. That will not fix our problem. We have to think outside the box and come up with innovative solutions, treat in place, treat the next day, and all those things are things we need to think about, because for a long time our solution in the business was transport. That was the solution. but it isn't the solution anymore, and it's not going to be an option for us because we're not going to be able to afford everything that we think we need to do. So I think all of us, whether we like it or not, are going to have to think about this and come up with very, very innovative solutions. And I think everyone today has shared some great ideas that are going. I love the idea of the PT. I mean, I've been thinking about this as well, because there's another program in North Carolina where they actually have a paramedic in care homes, and that rather than every time someone falls or transported, they actually get assessed by a paramedic that's in the care facility that decides whether they need to go, and they can do a video consult, so they don't have to be transported. Because if you work in an ER today, you see so many falls, and then you're waiting for the ambulance to take them back after their CAT scan's negative, and there's your big wait. All of these things apply together. We're all part of this together. So that's my thoughts.
So a part of me, as somebody who helps operate an ambulance service, you know, I'm all in favor of reducing red lights and sirens and improving safety. As I was talking to Kolby earlier about our ambulances getting damaged, going red lights and sirens. I'm so sick of that. When it's hard to get ambulances and they're skyrocketing in price. So that's all well and good, but then on the other hand, this is also a very threatening conversation when you talk about reducing numbers of transports, because that's what we get paid for.
Well, and that's why
Now, that's what you get paid for.
when we talk about payment
But
reform.
we gotta change that.
Yeah.
No question.
The two issues are separate, right? So how you get there is completely separate from what's the disposition, okay? So if your transport ratio is 80%, keep transporting 80%, but don't use lights and sirens to get to, 80% of your calls, because it doesn't matter. Changing payment models to get reimbursed for non-transport is the holy grail, which is what many people, many national associations working together are trying to get bills through Congress, the state level. Many states have passed state laws. That state, Pennsylvania is one. They were one of the first ones. Texas now, that they pay for the response, not the transport. That's the goal.
Yeah, and I would say to that, I think it should not be threatening. It should be an opportunity. And I know it probably feels threatening if we just think about what we did. I'm the medical director of the only agency in Pennsylvania that was in ET3, and I know there were a couple other agencies in the room here that were in ET3. To the question of what the public expects, nobody that we responded to in ET3 and kept in place was begging to go to the hospital. I mean, they were very happy to have an option. As a matter of fact, there was one woman that I was actually on scene, and it would have been very appropriate for her, and she chose to go to the hospital. And on the way to the hospital, she asked the paramedic, was he trying to tell me that it probably not going to get anything different at the hospital and I could have just stayed home? And he's like, yeah, that's what he was trying to tell you. But they're not begging for it. And the treat-in-place laws that are making some progress in the last year, I mean, I am very hopeful that you can never predict politics, but I'm very hopeful that those go through. If those go through, it's very good for the EMS agency that is in this to provide health care and be part of health care and provide health care to patients. It's not so good for the ones that are there for the action and excitement of, lights and siren response and haul them all to the hospital. But it could be very good for those that want to do health care, true
It's not
healthcare.
it's not a hard conversation to sit with a payer. We did it in Southeast Michigan, and we said, look, if you pay us double, we won't take the patient to the ER. And the payer stops for a minute and says, we're not paying you double for, wait a minute, what'd you say? If you double our base rate, we won't transport to the ER if the patient doesn't need to go. And even without their calculator, the payer figures out, I'm going to pay you $400 more than I did and not pay $6,000 for a 3-hour trip to the ER for a bunch of tests that was treated and treated. We shouldn't be afraid to put that conversation in front of the payers just that way. Pay us more, you'll spend less. But we've got to deliver the value proposition over the volume proposition, or we're stuck living and dying by volume, and that's your concern.
And if you provide good clinical care, those folks that demand to go to the hospital are demanding because of a psychosocial reason, not because of a clinical medical reason. Now, I understand there are all sorts of challenges in addressing that, but that's part of the problem.
Well, I just wanted to thank all of you guys. Great presentations today. No, I know. I'm not pulling the plug on you, John, but great material, very thought-provoking as always. And I was trying to press Dr. Kupas on this first thing this morning with the challenges with the slides, but it seems like hearkening back to the 4-minute and 8-minute response time thing, getting back to the core of today's point being the lights and sirens responses. Just would love to see an august group of this type here, if we could come up with like the top, 6 measures, non-response time related, and we all get the great list, and a lot of us use those, yada, yada, yada. But it's something briefer and simpler that could take the place of the 4 and 8 minute mindset that especially those of us that are very, very old still remember, to take the place that saying these 6 measures, and there's another 30, we all understand that, but these are what separate the good and the bad and the ugly system. So thank you all again, appreciate it. So Dr. Kupas, that's a charge for you to get some of these guys together and get that happening. So.
And Mark, you're beginning to see it. So a couple of the recent RFPs that have come out have specifically done that and said, yeah, we're going to track response times, but if you're really giving good clinical care, here are the metrics, good patient experience scores, good CCFs, good airway management, there's no penalty for the response time issues. Oregon, so we worked on Washington County, I just finished doing Jackson County, Oregon, rewriting their county ordinances, and the one that we just did in Jackson County, we took out everything related to response times except for echo calls, and replaced it with a system performance committee who will decide in the local community, here's your list of 20 metrics, pick the ones that are important to you, and start doing statistical control charts. That's the new standard in Jackson County, in Medford, Oregon, which is what it should be across the country. It's how you do it.
I got a multi-parter. Probably pertains more to Joni for the PSAPs and the EMD stuff. So a handful of the speakers, you're all talking about data-driven and make decisions based on data. Measuring patient outcomes and all that by EMD, there doesn't seem to be any follow-through on that. So as a PSAP, we're mandated to use EMD, correct?
If you are a PSAP that dispatches an ambulance agency.
Yes,
Yes,
correct.
your MCA
But the idea
should be
is
using
that
protocols.
as a user of EMD, how do I tell my taxpayers that I have numbers to show that this improves their outcomes, right? We get it on the front end, we use it, we follow through, but maybe if somebody can come up with a way to show me that there is an improvement, and I think it has something to do with the CARES reports maybe, but that would just be cardiac arrest. So that's part number 1. Part number 2, what do you think about a tiered, in the dispatch center, so we're required to use EMD, and we're held accountable to EMD all these calls, right? On this end, we're talking about focusing on the high priorities. What about just doing the high priorities with EMD? Does that make sense? Because once we do EMD, we have to follow up. We do our QAs, right? So I'm QAing all those bullshit calls that we're talking about on this end, kind of tearing them down. How about, has there been any thought about focusing more on the high priority on the EMD on the front end and our PSAPs? Because I'm pretty sure Chief Flynn was talking about it, that the shorthandedness in the PSAPs, right? So we're a big city, but we're short-staffed too. So I'll have it sometimes 2 people in there, and if I'm doing EMD and I'm stacking calls, but now I have to do the EMD for that same yeast infection we had yesterday. And then, by the way, it ends up in my bucket to be QA'd, so now I have to QA it. So it's like this cascading thing. So I don't know, any thoughts? There's a lot of smart people in this room. Maybe somebody can help me on that one.
So for the first part of your question, I'll go back to my comment about how 911 is historically terrible at collecting data, and if we do have it, we don't like to share it. So if I had better information for you on that, I certainly would. It makes it really challenging because 911 centers are all so different. So when even your nature codes that you use, if you have an EMD protocol system in your dispatch center, the nature code you enter into CAD doesn't even have to be the same thing that's on the card. So collecting data to understand at a statewide level how many calls we have that are actually this or this priority, it is so all over the place. And Emily and I have been talking about this for years, about how we can't get a handle on the data.
I'm gonna give you an outcome answer, okay? Like an actual outcome, because what we care about, yes, we can look at our disposition, that's not an outcome, right? An outcome is the humans after they leave wherever it is that we may or may not have taken them, right? So our office is a system, right? So trauma network, stroke, and STEMI, we're not gonna get everybody, right? But with our new system, it will all be integrated together and you will get outcome for those patients that you are associated with. So that's one thing. Two, the 911 centers should be at the MCA table, period. So though I'm this is preaching to the choir a little bit, right? But the MCAs are the hospitals. Case reviews shouldn't be used only for like punitive case reviews, right? So could an MCA say, let's look at all of the dispatches with this code and how many of them are actually being transported, how many of them being turfed from the emergency department in 45 minutes? Stuff like that, absolutely within the MCA's purview because it involves all of you. So that's the importance of getting the 911 centers into the MCA's professional standards review organization so that you can look from start to actual finish. Okay, sorry.
I don't. So
quiet and sit in my seat.
Well, no, you should actually be up here. So for the second part, when you're talking about the protocols, we would love for everyone to use protocols on every call because that's what they're there for, right? But the reality of it is those are customizable. You can use those protocols with the right policies and procedures, working with your MCAs, working with the vendors to make those, if you only really ever use them for echo calls. But my question is, how do you know it's an echo call unless you've used the protocols? You know, it really is an inclusive system in its entirety. But I think Dr. Bronsky had it.
So my answer I'll just kind of mixing it all in. As I said, we use medical priority dispatch, right? I'll be very open and honest. When I first came to Colorado Springs and started looking at the dispatch system and then took medical control over the dispatch system, I was not a fan. Okay, I was much more of a fan of the other systems that use medically trained people that could just make their own decisions independently and maybe have a better idea of what may be going on scene because they have experience out in the field, blah, 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 blah. But then I began to realize that when the medical priority dispatch is used consistently and correctly, it creates a stable foundation on which to build an accurate tiered response system. Okay, so if you don't have that, you're going to be shooting in the dark most of the time. And I understand the urge to say, well, let's just use it just for the critical things. Well, it's not that simple, you know, because there's gray zones. And in order to really catch, you know, for instance, I put up on my presentation how our CMED responses go all the way up into the deltas, okay? Well, you would consider deltas for, you know, pretty much critical, all right? They're not echoes, but they're just right underneath. And so how are you going to catch those? How are you going to really figure out what is critical, what's not critical, if you're not doing it holistically all the way through and creating a bedrock foundation on which to build these types of responses? Because these types of responses cannot be built without that foundation.
So I appreciate everybody, their time coming in, the sponsors who made today possible, the speakers who gave up time to come and share their thoughts, participate in the discussion. I think hopefully we all go back into our communities and our agencies and our departments and keep the discussion going, keep the contacts that we've made, keep kind of challenging each other with the difficult questions, and hopefully as we get together every year, we'll be able to report progress and have innovation in some of our systems and some of our communities. Because my fear as an agency person, and I those who know me know that there's a tiny little cynical streak in me from time to time. You know, I don't want to be the agency director that has to go to an injured or killed employee of mine, paramedic EMT, operating a vehicle, and we see it in the media sometimes where there's an emergency vehicle accident, sometimes when two emergency vehicles run into each other going to the same scene, and the agency administrator is in the newspaper saying, "We promise a thorough investigation." We know what's causing these things. It's the decisions, it's the structure, it's the historical perspective that we use in utilizing our resources that hopefully we can change. So thanks for everyone's time today. I hope you enjoyed the conference, the space, the discussions, and again, my challenge is to take it back to all of our respective organizations and take what we learned today and now try to go make change in all of our systems.